Worsening of any of the right ventricular parameters during pregnancy is extremely rare. Beta blocker is recommended for women who have evidence of arrhythmia, so frequent PVCs or ventricular tachycardia. Some will suggest beta blocker in all patients who have any clinical diagnosis of ARVC, so any evidence of structural right ventricular changes or arrhythmia. Cesarean section rates do not differ in ARVC from the general population and is really only indicated in the setting of significant left or right heart failure. An ICD, again, is indicated in a woman who's had a prior cardiac arrest, severe left ventricular dysfunction, or ventricular tachycardia. Women who have had syncope, it's also an important question to ask whether this may have been an arrhythmic syncope or faint. Genetic testing, of course, is important to assist with diagnosis and with family and neonatal screening. And when you have identified a pathogenic gene mutation, it can be useful for cord blood testing to test the infant at the time of delivery. Unassisted vaginal delivery is considered only if there is severe left or right ventricular dysfunction, unless, of course, there are some concerns about baby that would mandate operative delivery. I recommend telemetry during labor and delivery only if there's a history of serious ventricular arrhythmia. Clinical neonatal screening is something something we discuss with our pediatric colleagues, but this disease typically manifests after the age of about 10 years old. And so screening of the newborn with ECG and echo may be impractical. However, again, if there is a pathogenic familial gene mutation, this can be helpful to identify a child who may be at risk later in life.